To get an answer to my research questions, I have gathered data through surveys and interviews. I sent an electronic survey to alumni of 4 accredited dental hygiene schools via the dean or program director of each school. Out of approximately 70 dental hygienists who received the survey, 30 responded to the survey. I also interviewed 2 dental hygienists from Los Angeles Dental Hygiene Society, 2 general dentists, and 2 periodontists. When alumni were asked about the program curriculum on gross debridement, 40% responded that they were taught gross debridement is okay to be performed if full mouth exam is not possible. 33% were taught that the gross debridement should never be implemented, and the remaining 27% responded that they were never taught about gross debridement. I was very surprised by this result because I thought I will get 100% were taught gross debridement should never be performed. I also asked alumni when they use gross debridement at their office. 30% said they implement gross debridement when full mouth evaluation is not possible. 37% said that gross debridement is part of their protocol, and every patient who needs scaling and root planing would have gross debridement before that. That means no matter if they have a lot of bulky calculus or not, and no matter if the dentist can do the exam or not, they will have the gross debridement done. 33% said that they don't implement gross debridement. My other question was, how long after gross debridement does the patient come back for the full mouth exam? Keep in mind, Code 4355 set by American Dental Association says that full mouth exam and gross debridement should not be performed on the same day, and patients typically should come back after 14 days. Having said that, 47% of the offices perform gross debridement and full mouth exam on the same day. 37% of them do the full mouth exam after the gross debridement, and very surprisingly, 10% do the full mouth exam before the gross debridement. 10% bring the patient back between 2 to 13 days. 0% bring after 14 days, and 10% varied between patients. And 33% of gross said they don't implement gross debridement. I asked everyone in my interview if gross debridement could be replaced by scaling and root planing at the initial visit. Everyone answered yes. Here are some of the comments. I would absolutely prefer to start with scaling and root planing instead of gross debridement. I had brought that up to the dentist I worked with before, and he was concerned about the time. This was said by a hygienist. If a patient has that amount of calculus, I think the patient needs to go through quadrant scaling and root planing anyways. So I think this gross debridement is a superfluous type of procedure. This was said by a periodontist. I learned about gross debridement 45 years ago, but I think it is a matter of preference, and if insurance company pay for 4355 or 4341, which is the scaling and root planing, in 1 or 2 visits. I think it becomes a political question rather than judgmental. At the end, we want to get a healthy tissue, whether you do gross debridement and quadrant scaling together or quadrant scaling only. This was said by a general dentist who actually does gross debridement before scaling and root planing, and after scaling and root planing, he does the full exam. I also asked the dentist who does not implement gross debridement what she would do if a patient comes in with a lot of bulky calculus and she cannot implement a full mouth evaluation. She responded, if the amount of calculus is so severe that it interferes with my ability to diagnose caries, which is the same as cavities, the patient is well informed that I either hold off on diagnosing caries or make an attentive treatment plan with the understanding that we may find few more cavities after the completion of scaling and root planing. I asked the same question from the hygienist who does gross debridement at their office. This is what she responded. I believe the dentist can tell from the radiographs if there are bone loss or cavities that are emergent and may need an immediate treatment. If there are caries that are not obvious on the radiographs, a patient can wait till after the scaling and root planing to be re-evaluated with a clinical evaluation. I also have to mention that dental hygienists can help with caries detection and identifying areas of concern while cleaning the teeth. Now let's go back to my research question. What were the dental hygienists taught in school about gross debridement? 73% were taught about gross debridement, but only 33% were taught not to utilize this procedure due to its adverse effect. Are dental professionals aware of the potential adverse effect of gross debridement? From this survey, 33% of the dental hygienists are aware of the adverse effects of gross debridement, but 67% are still implementing gross debridement. In my interviews, everyone except Dr. Shore, who has been practicing for 45 years, knew about the adverse effect, but still 3 out of 6 are implementing gross debridement. Can gross debridement be replaced with an alternative complete periodontal treatment? In my interviews, 6 out of 6 said yes. Is full mouth debridement the same as gross debridement? According to the literature, full mouth debridement is cleaning the whole mouth within 24 hours interval. This procedure has the same effect as scaling and root planing and is a definitive procedure. Both patients with gingivitis and periodontitis can benefit from full mouth debridement. Gross debridement, in contrast, is an incomplete removal of bulky calculus that interfere with the ability of dentists to perform comprehensive evaluation. Code 4355 is gross removal of plaque and calculus that interfere with the ability of the dentist to perform a comprehensive oral evaluation. This procedure needs to be followed by definitive periodontal cleaning. Comparing these 3 definitions, we can conclude that full mouth debridement is not the same as gross debridement because it is a complete cleaning. And 4355 is the same as gross debridement. Therefore, 4355 has been named incorrectly. What I learned from this research. Gross debridement is an incomplete procedure that has many side effects. Not all dental hygienists are taught about gross debridement procedure the same. Even though 33% of dental hygienists and 75% of dentists are aware of the gross debridement side effects, more than 67% offices are implementing gross debridement. The incomplete gross debridement procedure can be escaped and replaced by an alternative periodontal debridement. Some of the side notes. The comprehensive evaluation may follow the alternative definitive periodontal debridement. Dental hygienists can help with recognizing the areas of concern. Bone loss and emergent caries or cavities can be detected from the radiographs. I also noticed that dental offices that utilize gross debridement are not following the American Dental Association guideline for this procedure. According to Dr. Blair, 67% to 75% of the time, insurance companies reject this procedure that the dental offices send because dental offices, they don't follow the ADA guidelines. Also, the code 47% of the offices implemented gross debridement and comprehensive evaluation on the same day, which is not the same as ADA guidelines, and 10% complete comprehensive evaluation before the gross debridement. Code 4355 has been named incorrectly by full mouth debridement, which is a definitive full mouth cleaning. What could be the solutions? Both dental and dental hygiene schools should focus on gross debridement and its adverse effect. Offering continual education courses would inform dentists who have been practicing for a long time about new guidelines on gross debridement and how it is no longer recommended. And most importantly, American Dental Association, who always insist of doing no harm, could encourage dental professionals not to implement gross debridement by revising the definition of this code. I would like to take you to American Dental Association website where it talks about the codes. I have it here. It says, requests for CDT code changes, additions, revisions, or deletions may be submitted by any interested party, individual, and organizations at any time. Therefore, I would like to request a revision for the Code 4355 definition to full mouth debridement, a definitive non-surgical periodontal debridement of whole periodontium in 1 or 2 subsequent appointments within 24-hour interval, using a power-driven ultrasonic device and hand scaling. Full mouth debridement is not to be used as an incomplete gross debridement procedure. At the end, I would like to thank Los Angeles Dental Hygiene Society for all their supports, deans and program director of dental hygiene programs helping me with sending the surveys, dentists and dental hygienists who I interviewed and took the survey, Dr. Coladas and Professor Amperon at Pepperdine University who guided me with this research. Thank you, and I hope you enjoyed it.